Varun Paranjpe, Senior Director, Product Marketing at Innovaccer. So over the course of the last few days at this conference, and really the last few years, we've heard so much about how AI is going to transform every industry that we all work in. But what hits closer to home than our own health and the transformative potential there? So that's why Innovaccer is thrilled to be hosting TiEcon's Healthcare and Life Sciences track with the theme of AI in healthcare. For those that don't know, Innovaccer is a healthcare AI company that helps providers, payers, public health, and life sciences organizations activate the power of data to advance health outcomes for everyone, everywhere. Today's program tackles three critical dimensions of healthcare's AI revolution. First, our executive roundtable will cut through the hype and talk about where AI has actually delivered on its promise and where there's still potential and what challenges remain. Second, we have a topic that's near and dear to everyone that's dedicated their career to healthcare, and that's building the next generation of healthcare workers so that we can ultimately deliver better care to more people. And we'll conclude with our CEO leading a forward-looking discussion on AI agents, how these autonomous systems are reshaping healthcare operations, what organizations need to do to future-proof their system so that they're able to take advantage of AI agent technology while maintaining clinical excellence and patient trust. So with that, I am now pleased to welcome Dr. Brian Silverstein, Chief Population Health Officer at Innovaccer, and our esteemed panelists who will lead our opening panel on the promise versus performance of AI.
Thank you for that fantastic introduction, and good morning, everyone. So excited to be here, and it's so great to have a conference where we're going to have more authentic conversations. You know, a lot of times you go to these conferences and everyone's talking about the hype and you don't actually understand what the reality is. And I have just two amazing panelists that are really doing some meaningful work, and we're going to get to hear the real stories. So I'm going to give brief intros, but I'm going to let you guys do full intros for yourself. And so Conrad is an SVP at Sutter. In addition to the fact that he's a cardiac surgeon, so you could always talk to him about the clinical stuff. Fun fact about Conrad, he actually is from Italy, he's fluent in Italian, and he spends a couple weeks every year in Italy. So if any of you want to get like travel tips or other things related to Italy, then he's going to be your guy. And also, obviously, with all the different clinical as well as AI, we're going to get there. And then also Aparna, she's also an SVP at Sutter. And Aparna, if you want to talk about hiking, she's been to Alaska, she's big into hiking. So if you wanted to talk, she's been to the Grand Canyon, then those are some of the other areas of expertise that she's going to be able to field. So now that I've given your real introductions, maybe if you want to talk a little bit more about your day jobs, would love to hear a little bit about what you're doing at Sutter.
Oh, Brian, that was great. Good morning, everyone, and thank you for the opportunity. It's wonderful to be here and talking about AI, especially in the spirit of healthcare and how AI can transform, nearly 18% of our GDP of the United States that's being spent on healthcare, and yet when we think about what we're getting in value towards that dollar spent, it's decreasing every year, right? It's on the linear scale is like going on the opposite direction versus how AI is taking every other industry by storm on an exponential basis. So when we talk about value in healthcare, that's what we do, and Conrad is going to talk about his. While he's not operating on hearts and fixing people and saving lives, he's my clinical dyad partner. Together we work on helping Sutter Health, which cares for over 3 million lives, patients in Northern California, help us move from volume to value. And value is really important, and I know we're going to talk about this further in the discussion. It's about improving access. It's about making things efficient. It's about creating, speed in which a patient can really get to seeing their doctor or their caregiver in a timely manner. That's what we try to do through what we call our day jobs as population health and Sutter Health Plan operations.
Conrad?
Thanks so much, Brian. Thank you, Aparna. I like to introduce myself as Aparna's DIAD partner because I like to celebrate the fact that at Sutter Health we're under the leadership of, and I was glad that our CEO, Warner, was mentioned. Under his leadership, we really do have a vision around becoming a healthcare delivery system that builds on its history and heritage, which I think is justifiably proud in serving many, many diverse communities across Northern California, now into the Central Coast. But building on that to become a system that is not only there to rescue people or combat their disease, but actually to promote their health. The notion that the healthcare system that I think will best serve the public good in the United States, including here at home, is one that is there to catch folks when they fall, but hopefully there also to keep them from falling if that's possible. And once they've fallen, restore them to a place of health and well-being and work to maintain them there. I think that is the journey of adding value-based care, excellence, capabilities, but also, frankly, attitude and culture into the mix. We were discussing at dinner last night some of my travels and contact with some really important mentors and friends. This includes in India. Samir Mitra is here. He's one of these folks whom I met in the course of receiving a lot of mentorship from an important figure there, Dr. Devi Shetty. And what I see there and other places in the world that I would like to see here is an attitude and a mindset of real world abundance facing real world scarcity. I think in the United States we often take an attitude of scarcity in facing real world abundance. It's a problem of how we allocate our time, our effort, our resources, and our investments. And I think, Aparna, you said it well. This is about improving the quality of healthcare for everyone who needs it because we're making investments differently. And frankly, getting back to the theme of today, we're using tools, technologies, and upskilling ourselves in ways that permit us to do that at the right level of scale.
Appreciate all those great introductory comments. And I think one of the things I'd like to kind of dive in is obviously we want to talk about AI. Everyone's talking about all the different concepts, but one thing that I think is unique is that you've actually implemented some programs and gotten results. And so I know you've got a good program with sepsis, you got something with cardiac, so pick your favorite program. And I'd love to talk about conceptually how Sutter you're thinking about AI, but then tell me about the reality of what's working and perhaps some of the bumps that you encountered along the way.
Sure, maybe I'll start with this. I want to be clear, first of all, I know Aparna joins me in this. We on our team and we at Sutter Health want to be very clear that we are on a journey like everybody else is on. We, to your point, Brian, are starting to see some early results that are rather promising, but we're trying to harness potential and turn it into delivery. And we're on the road to doing that. I'm not going to sit up here and try and convince anybody that we've invented already the better mousetrap, so to speak. But we feel we're on that road. To the point of your question, I think the promise of technology that has heretofore not been delivered in healthcare necessarily is around customized, prioritized, targeted predictions. Not about who's going to necessarily incur cost to the healthcare system, but what condition will drive the consumption of healthcare resources that ultimately translate into a total cost of care equation. You mentioned sepsis. To give a concrete example around that, this is going to be a surprise to anybody, but in our environment, if we look, for example, at our Medicare Advantage patients who are in a managed Medicare program, the number one driver of resource consumption and cost is sepsis, systemic infection in the hospital setting. Now, laddering up to that in the hospital setting are costs being driven by 3 significant conditions: respiratory conditions, often pneumonia, urinary tract infections, and skin infections, cellulitis. All of those cause hospital admissions that might have been avoided. But if you look at the high-cost driver, which is sepsis, which is, by the way, the most clinically ominous manifestation of infection, if you bring it down to a human context, 41% of those sepsis indications are for people who had a cellulitis or a urinary tract infection or a respiratory condition that was allowed to get out of control, not because somebody missed, but just somebody didn't have a line of sight on it. So what we want to do is move upstream in that process, and we have started to develop a universal data set that we can train machine learning on that permits, through our common electronic health record, the identification of patients who are prospectively at risk for one of those 3 index infections and intervene on those in the ambulatory outpatient environment to prevent their ultimate inpatient admission. And we're seeing some really good results in that and feeling very positively about the trajectory we're on there.
You know, it's so exciting. I think one of the challenges that it's interesting. I think in healthcare, we have literally the brightest people in the world. It's a huge component of the GDP. However, when you look at all the data and information that we have, commonly we're not looking at the right metrics for actually prediction. The most common data we look at is claims data, and claims data, it's like driving, looking in the rearview mirror. Not that it isn't important every now and then to look in the rearview mirror, but nonetheless, and so I love how you're actually pulling some more substantial data set there to be able to actually identify and intervene before we're having the accidents occur. Now, Aparna, I know something that is really you're passionate about is the whole payvider space. And certainly this is a little bit of a shift from where we're talking about some of the ways that you could use data to thinking about from a economic point of view. You've got the providers, you've got the payers. There's always been a certain degree of healthy tension there. I would love to hear some of your perspectives regarding how is it that those come together specifically around AI and being able to do things that are going to ultimately benefit patients.
Yeah, absolutely. I just want to build on what Conrad said. Also, I don't think it's, my background before coming to Sutter, I'm fairly new at Sutter, just a few months here. I spent nearly 25 years all on the payer side. So those of you who do not know what payer, these are insurance companies, right? You know, United Healthcare, Centene, Cigna, et cetera. And there's a reason why I'm sitting in the chair I'm sitting in at Sutter. It was a very intentional, you know, kind of a professional life-altering decision to leave the payer world after nearly 25 years and say, if we really want to make an impact on the communities we serve and really try to put a dent in the medical cost trend. I know we keep talking about the triple aim and bending the cost curve and, you know, all of those things, but everybody tries to work in their own silos, you know, the providers and the payers, right? Even some of the most sophisticated venture capitalists, you know, we had the fortune of sitting through a really interesting presentation, but even when in their world, when they're thinking about solutions and, you know, how we want to tackle the healthcare problem, we still talk very much a lane. You know, you're in this lane, you're in this lane, you know, these are your problems, these are your problems. But when we put ourselves in the shoes of what we all experience as patients every day, right? Not every day, hopefully not. How many of you think of calling your payer, an insurance company, when you really need health care? I don't, right? I bet many of you in the audience, you don't. We all know the trust we as human beings place when it comes to healthcare decisions is, you know, we trust our nurses, we trust our care providers, physicians. The trust factor is so high over there, and yet we operate like, you know, we're all like these very independent, siloed organizations. So when we talk about hitting on the true triple aim and really making an impact and stretching the dollar, again, going back to my comments about for every dollar we spend in healthcare, we get diminishing returns on a year-over-year basis. If we want to really change that idea, this notion of pay wider, right? How do we really bring the right economics to the provider side so that we feel that we're bringing that value equation into the picture, right? So that's really is the point about what we're talking about. And again, I want to build on how does it manifest in everyday. I want to build on what Conrad said. We can identify, right? We use predictive analytics and AI to identify patients with propensity to show up in an ED or get readmitted from a skilled nursing and so on and so forth. What do you do? What does it mean to activate on that information? And this is where, if you put the pay wider hat and you say, hey, this is not about volume. Let's not just get them into an acute setting or an ED setting. Can we intervene, and what exactly does that intervention mean is where the true value creation is. Right? That's how we partner together while we're working on the clinical identification of what are some of these categories we want to go after, and how is the data and AI informing us. But sometimes there is a human intervention. That's healthcare, right? And that's really the impetus of getting into the clinical journey of a patient and helping them kind of get them out of a very uncomfortable ED visit or an inpatient visit. So this truly is the promise, in my opinion, of breaking down those barriers and silos, and the physicians and the providers, the health systems, especially like Sutter, an integrated health system, moving away from volume to value.
Thank you for sharing that. I think that everyone in the room probably, shouldn't say everyone because you have a mixed audience. I used to work at a payer, and payers are not winning any popularity contests these days. That's, I think, something for certain. And also, as much as your comment, thinking about who am I going to call in a time of need, I think most people probably view payers as more obstructing care rather than actually facilitating care. So it's phenomenal that when you combine the two together, hopefully you're going to be able to develop some specific programs or ways that you're able to, by bridging that gap, will result in better outcomes for patients and also lower costs.
Right.
Brian, I wonder if I wanted to dwell on a point you just made, which I think is really important, if I could for a second. I think the question is, you brought up claims data versus health record insight. And the truth is you need both.
Yes.
Right? So if we look at the healthcare system, we have provider and we have payer. And you asked about the pay wider, and that's going to the same place. We need to build strength through partnership. Now, sometimes that can be financially linked. Sometimes it can be partnered through contractual arrangements. There are a multiplicity of different ways to do it, but here's the effect we need to create. Value-based care, at the end of the day, and technology's role in helping us to become more competent and to perform with excellence in that space, fundamentally hinges on two things that we've not ever located at the heart of healthcare, which is really quality. Mm-hmm. And that is access, and insurance companies are infamous for constraining access as a means of achieving sustainability, the margin to support the mission. And the other side is efficiency, and healthcare systems are infamous for being inefficient. So value-based care, by locating the importance of opening access for the right kind of care in the right hands, at the right place, at the right time, locating that alongside efficiency and proper stewardship of scarce resources in the heart of quality, now you've got a working humanistic definition of why it makes sense to utilize technology to liberate human potential, not constrain it, and then hold human potential accountable to do what it and only it can do in service to that. And I think that's what's very powerfully resonant when I hear Aparna tell the story of how I was with the payers, I wanted to be in a provider, not because I want to turn my back on the importance of the question of efficiency, but rather because the efficiency will only be mattering to human beings if we deliver it through delivery.
Absolutely, and certainly I think you're highlighting one of these key challenges is that the information that exists about an individual is in multiple locations. And so certainly, the claims data absolutely does have value in different forms and fashion, but the claims in and of itself is of what's more limited value. The clinical data is important, and lab data is important, pharmacy data is important, and fill rates. There's all of these different, it's a whole milieu, and without being able to put it together, no matter how good the AI is, if we don't have the right inputs, we're not going to be able to actually come up with the different predictions. I know, Conrad, another program that you have that's worked really well is, I believe, in CHF. And so, and I'd love to hear about the data elements that you're using in that program, and what did you find that worked, and what also did you find that, this didn't work?
Yeah, I'll go back to the playbook I described earlier, which is, first of all, and this is not a small step, synthesizing a truly universal data set. Taking the 3.5 million patients that Sutter serves and having their data in an environment of synthesis, so that you can then train machine learning logic on specific conditions and identify specific risk factors that line up along lines of clinical risk, behavioral risk, and social risk. So in the second largest cost driver, in our system at least, congestive heart failure admissions that are preventable, it's very interesting when you do that what you find. What you find is that people who live alone, if you look at the top 4 drivers of predictive risk, age is in there, living alone is in there, the concentration of a certain ubiquitous body protein in the blood, albumin, is in there. And you say, well, wait a minute, age is age. But living alone, what is that about? Why is that a risk? I mean, that's as important as whether you've had a prior heart attack or not in this Medicare Advantage population. And then the serum protein level, what's that about? Well, that's about nutrition. That's about food insecurity, right? Living alone is about what the Surgeon General has called an epidemic in this country. It's about loneliness. It's about the failure of social support networks to be able to buoy people up in good times and in bad. These are factors that are popping up in our universal data set. They're being worked on by the machine learning logic, and they're driving interventions that include the creation of a senior clinic network that not only takes care of people's quote-unquote traditional clinical needs, but it's offering them transportation and access. It's offering them nutritional consultation and, if possible, even help with meal preparation. And why can we do this? Because fee-for-risk payment models permit us to invest upfront in healthcare delivery model innovation. The fee-for-service model, you're like in claims. You're always looking at where this puck was. You're not going to where the puck's going to be. That's the challenge we have. Rendering that efficient and scalable is the property of healthcare's absorption of the technological revolution that we're living through right now. And machine learning is anchoring that effort for us, and it's yielding an ROI of 103% on a pilot program that we had last year from a financial perspective, but more importantly, people aren't having to go to the hospital or the ED multiple times a year anymore because those things are being dealt with.
Conrad, that's such a fantastic story. And really, if you think about in other industries, there's so much data that's being used where the AI is having such of a great impact. And even you think about simple things, like not simple by any stretch, but airplane engines. Monitored, everyone knows exactly what's going on, control centers being able to then say, okay, we're going to preventively do something. When it comes to something that I consider to be way more precious to humans, we're not doing that, but you are. And that's amazing how you're able to actually get that input of things, social factors, that are incredibly predictive where they don't actually exist in any large database. And so really applaud that you're pulling the correct inputs together to be able to get the outputs. I'd suggest, though, related to that, and Aparna would love to hear your thoughts on this, as we're pulling all this data in, you've got to think about governance. And so what are different ways that we're going to ensure that the data is coming in is accurate? How are we going to ensure also that the right people have the right access? Would love to hear your thoughts on that.
Yeah, it's a really important notion that we have to be, when we think about healthcare, there's a high degree of privacy is really important, right? When we need to think about the accuracy, it's not just privacy, but accuracy. And then there's a regulatory side of that too, right? Not just privacy for the sake of protecting information, but we have to follow the HIPAA and other regulations. There's a compliance aspect to it. So when we think about AI in the context of Sutter Health and all the wonderful things we want to do, kind of delivering on the promise of all of that, we do need strong governance in it. So I think some of you, maybe 7 of you were in Warner's session yesterday, maybe more than 7. But he probably talked a lot about this concept of integration and ensuring that the digital team is very integral into the business operations. And we actually are in the process of hiring. Conrad and I were very fortunate to meet with the person, an AI officer focused on not just on the governance, but that's going to be a really, really important role and the responsibility, accountability for that person coming on. But ensuring that all of us from the business standpoint are thoughtful about how the governance is kind of taken into consideration when we think about launching solutions.
Absolutely. And in a moment, we're going to give the audience a chance. We probably could take 1 to 2 questions. So if you want to be one of those people, I'm not sure I could see if you raise your hand, but if you go into the aisle, there's a chance that maybe we could recognize you, so start to consider that. But absolutely appreciate some of those thoughts and love that part of this is bringing the humans in to make sure that you have the appropriate people that have the expertise to be able to provide some of the oversight. And just love actually that you've got all these great pieces coming together where you've got the payer, you've got the provider, you've got actual programs that you're doing using AI and ML and making a difference in patients' lives. I mean, it's just really inspirational. And so with that, we have probably time for 1 to 2 questions. And so I see a hand here, but someone behind you has the microphone. So we'll do the person with the mic first, and then we'll move it up.
Thank you. Conrad, this is a question for you maybe. So I come from the pharma world. I used to run a team of analysts working on clinical trials. And I want to ask a question about partnerships with pharma companies. You mentioned the power of predictive analytics for preventive health. How about, choosing the right patients for clinical trials? As you know that there's a lot of failure that happens in drug development. Can you talk about the balancing act of using that information for better patient stratification in clinical trials while ensuring privacy as well? And what are you doing in that, and what are the opportunities for entrepreneurs in this room?
I'm so grateful to you for asking that question. Part of my accountabilities portfolio is to oversee research and academics at Sutter as well. And we definitely, both Aparna and I, feel very strongly that the learning healthcare system has to be one of the essential catalysts or ingredients in actually transforming the system in the direction of acquiring value-based care capabilities. You hit on a really important area. The predictive analytics around, who is going to develop a condition that will require acute care services that is potentially preventable. I want to relate it, that context, I want to relate it to the one that you've just pointed me towards, which is imagine a circumstance where we were able to leverage through partnerships or through internal efforts precision medicine capabilities around biobanking, for example, that would permit us to understand whether there were cohorts of patients for whom we bore clinical human risk, but also financial risk, who had a particular genetic predisposition to actually not glean benefit from what is otherwise thought of as a standard of care, pharmacologic intervention, a medication, and instead would benefit from an alternative that isn't necessarily as prominently displayed or perhaps even on the formulary. Well, first of all, we learn to update our formulary because we understand what real-world patients look like. But secondly, from the perspective of that patient and the cohort that they belong to, we can actually redirect them and their caregiver towards a prescription that will provide them with an intervention, and I'm just using this as a simple example, but an intervention that will actually permit them to glean the benefit of this and not end up in the emergency room and have people going, well, he's on all the right medications. I don't know why you're here. You must be really indiscreet with your diet, or you're a couch potato, or you're this or you're that. No, it turns out the patient is just not somebody who's going to respond well to a medication like Plavix. They need something else. So I think integrating what I call the learning healthcare system angle on all of this into it, and doing so through powerful collaborations with those that can amplify our efforts, is an important part of using technology to drive value-based care performance excellence.
Thank you for the question, and with that, we are at time for this panel. So good news, though, there are 2 more panels that are going to be coming up, and also Conrad and Aparna are going to stick around, so if you had some questions about Italy or hiking that you didn't want to ask in front of the group, you can ask those, but let's give them both a round of applause. Thank you both so much.